Good afternoon, dear students. Today we continue cycle of lectures for third year students, MA groups who have a first semester, and we continue some module of signs and symptoms of cardiovascular system disorders. And the next lecture from this topic, today's lecture, is named Acute Coronary Syndrome. It is a second lecture, is in a cycle of two lectures in general about coronary insufficiency, but in previous lecture we discussed more about chronic forms. Today we're going to discuss acute forms, and we name it usually the total term acute coronary syndrome. Plan of our today's lecture. We're going to give a definition to acute coronary syndrome, discuss epidemiology, risk factors, etiology, mechanisms, classification, clinical investigation, and diagnosis. Let's give definition. Acute coronary syndrome has evolved as a useful operational term that refers to a spectrum of conditions compatible with acute myocardial ischemia or myocardial infarction, that are usually due to an abrupt reduction in coronary blood flow ranging clinically from the ST segment elevation myocardial infarction to presentations found in non-ST segment elevation myocardial infarction or in unstable angina. It is three main forms of this syndrome. Most patients with ST elevation myocardial infarction or STEMI develop Q-positive myocardial infarction, and few develop non-Q positive. Most of those without ST elevation develop non-QMI, and only few may develop Q-positive myocardial infarction. That's why mostly it's a relation between presence of pathological Q wave or Q-positive MI and presence of ST elevation or ST elevation myocardial infarction. But these relations are not obligatory. In some patients, it can be variance. The acute coronary syndrome associated with a high health care costs, frequent recurrences, and hospitalization, that high risk of sudden death and short-term mortality. That's why this topic it is quite important because this disorder are very dangerous, very serious, and unfortunately very often. Let's give definition to different form. What is unstable angina? Unstable angina is defined as myocardial ischemia at rest or minimal exertion in the absence of cardiomyocyte necrosis. Among patients presenting with suspected non-ST elevation acute coronary syndrome, the introduction of high-sensitivity cardiac troponin measurements in place of standard troponin assays resulted in an increase in the detection of MI and a reciprocal decrease in the diagnosis of unstable angina. Compared with non-STEMI, non-ST elevation myocardial infarction patients, individuals with unstable angina do not experience myocardial necrosis. It's just an acute ischemia. Have a substantially lower risk of death and appear to derive less benefit from intensified antiplatelet therapy as well as early invasive strategy. A definition of myocardial infarction. The universal definition, it is quite short. It usually described as MI defines cardiomyocyte necrosis in a clinical setting consistent with acute myocardial ischemia. Okay. Our definition, we with our group of scientists, group of teachers, we like more detailized definition of myocardial infarction, and it's sound like acute myocardial infarction. It is a disease or Clinical syndrome accompanying other diseases, which is represented by acute coronarogenous aseptic inflammation of the part of heart wall, and clinically correlates with the stress reactions of body control systems and is determined by the extent, localization, nature, and stage of structural transformations in the infarction zone, as well as circulation changes and their consequences. Worldwide, coronary artery disease is the single most frequent cause of death. For example, in Ukraine, the cardiovascular disorders and especially coronary artery disease take the first place in adult mortality. Over 7 million people every year die from coronary artery disease, accounting for 12.8% of all deaths. Every sixth man and every seventh woman in Europe will die from myocardial infarction. You see how often this problem. The incidence of hospital admissions for myocardial infarction varies among countries. The most comprehensive STEMI registry, the most full, is probably in Sweden. There is the incidence in 66 STEMI per 10,000 per year. It is quite often. For example, acute coronary syndrome incidence in the Spanish population. And you see that the highest one now is in adult man under 74, and prognostically it will be on the same level, but in 20-30 years it is prognosis for a dramatical increase of incidence of myocardial infarction in more aged men and for women. Quality of diagnosis was not the same over the years. For example, 20, 30, 40 years ago, the diagnostics of myocardial infarction was much less effective, because it was no test for cardiac enzymes. And for today, the testing on cardiac enzymes, it started from year nearly 1998. It very increased in a higher level, a general level of diagnostics of myocardial infarction. Risk factor, you remember this slide from the previous lecture. First and the most often cause of coronary artery disease in general and for all acute forms, and especially for MI, it is atherosclerosis. In a spectrum of all coronary disease, you see in the middle of this scheme, it is acute forms. It is acute myocardial ischemia, it is coronary thrombosis, myocardial infarction, and its complications. Etiology of acute coronary syndrome. The hallmark of an acute coronary syndrome is the sudden imbalance between myocardial oxygen consumption and demand. It is the general definition you remember from coronary artery disease as for chronic forms, as for acute. It is imbalance between supply and demand of oxygen. But if for chronic forms it more gradual, here it is always sudden, that lead to acute ischemia or in the same moment to necrosis in a case of block of coronary artery. The imbalance may also caused by other excessive myocardial oxygen demand in the setting of stable flow-limiting lesion, acute coronary insufficiency due to vasospastic angina, coronary embolism, coronary arteritis, non-coronary causes like hypotension, severe anemia, hypertension, tachycardia, hypertrophic cardiomyopathy, severe aortic stenosis, or non-ischemic myocardial injury like myocarditis, cardiac contusion, cardiotoxic drugs. Multifactorial causes include stress, cardiomyopathy, pulmonary embolism, severe heart failure, sepsis, etc. Mechanisms. If we talk about unstable angina, until local coronary circulation disturbances cross the time, it leads to reversible ischemia. Yes, it leads to ischemia, but still no necrosis. And if, for example, in one moment we remove obstruction, we renovate coronary blood flow, all changes in myocardium reverse to normal. In another hand, myocardial infarction develops when a local coronary circulation disturbances cross the time threshold and make the ischemia is irreversible, or it means necrosis. If cells are die, these changes are not reversible. Just one way to normalize it, it is recovery with a scar formation, but myocardium will be not the same as previously. That's why we name these changes in irreversible. Key moments in mechanisms of acute coronary syndrome. They were selected by evolution and consist at systems and local systemic and local levels. Now we will talk a little about separately systemic and separately local. These mechanisms are aimed at providing most favorable of possible the acute coronary syndrome courses. The disturbances build complications of the acute coronary syndrome. Mechanisms of systemic level. The response of body system to an acute coronary syndrome is realized through stress and manifests itself as brain-mediated sympathetic activation and increased functional activity of hypothalamic, pituitary, and adrenal systems, with a change of functions of all target organs. Course and outcome of the acute coronary syndrome, all other conditions being equal. An adequate organization of stress, we name it eustress, becomes of primary importance. For STEMI, leukocyte reactions are important for the further development of the process. These reactions are triggered by the ejection of leukocytes from the depot to the systemic blood flow. Since the depot mainly contains neutrophils, leukocytosis appears as the shift of the cell count. Neutrophil zones are positive for chemotaxis. Infarction zone products getting in the blood flow play the role of attractants for them. The activation of neutrophils appears as a hyperenzyemia, higher contents of eicosanoids, leukotrienes, in particular protein carbohydrate complexes, and other biologically active agents. Stress is changing as the process develops and leukocytosis declines with the leukogram changes. Granulocyte counts decrease and their functional activity is suppressed, while agranulocyte counts and their activity increase. The structural change of the leukogram is the result of controlling effects of infarction zone product engaging the blood flow. Neutrophil decay products from the infarction zone are repellents for neutrophils and attractants for agranulocytes. As a result, an enzyme level of blood falls, while the protein and protein carbohydrate complexes content grows. There are the systemic manifestations of an inflammation process in the infarction zone. With the termination of acute myocardial infarction phase, regulation problems disappear and not a trace remains of the stress. And it was systemic mechanism. Local mechanisms It goes in several levels. Local, systemic and local. Local level, it is the heart. It is specifically myocardium. What changes go in myocardium? On these panels on the picture you see there are two that in patient with MI, a myocardium contains two zones. It is infarction zone or core zone with microvascular injury, edema, intramyocardial hemorrhage, a contraction of bent necrosis, and necrotized myocardium. And it contains a border zone that is not still in necrosis, it is acute ischemia. In this zone, it is intact microvasculature, neutrophil accumulation, granulation tissue, occasional microthrombi, and it can be viable myocardium. And usually border zone placed around the core zone. The components of pathologic process are not only changes in the infarction zone and recovery of heart shape and size, but also adaptive changes of the heart biomechanics. What goes in infarction zone or core zone? All that happens is inflammation. It is special, aseptic, alternative, but still inflammation. The first one is ischemia, reversible myocardial changes. Usually on ECG it looks like non-ST elevation, myocardial infarction or STEMI. The transfer to irreversible changes to STEMI marks the onset of necrosis, in which the transfer from ischemic changes in the infarction zone to necrotic ones. The inflammation starts in accordance with its traditional scheme. The necrotized myocardium undergoes destruction and decay products are removed through the peri-infarction zone. The necrotized myocardium is specifically destroyed by neutrophil getting the chemotoxins from blood into the infarction zone and producing cathepsins. The emigration rate is rather high, about 2-4 mm per hour, and even the largest possible infarction is infiltrated by neutrophils at 6 hours at the most. At the same time, fibroblasts, precursors, enter the infarction zone and the recovery process begins. It is impossible to separate necrotic and reparative processes. They usually go together, and look at them as the individual ones. They are synchronized and interconnected not only at the level of infarction zone itself, but also in systemic blood level. The result of unnatural inflammation course in the infarction zone is formation of full-fledged scar in the place of necrosis. Maturation of granulation tissue results in its consolidation, followed by a decrease in infarction zone sizes. Depending on conditions, they can decrease by 25% or more. I should remind those who want to strongly intervene in the infarction zone that phenomena occurring there, like inflammation, compensatory, and adaptive responses. They are protective reactions originated as a result of evolution. That's why these actions will be non-effective and even dangerous. We may intervene at these processes, but very, very carefully. Systemic mechanisms in the infarction zone are interconnected through the peri-infarction zone. First of all, through its microcirculatory bed. That's why all processes that goes from the infarction zone, they go through the buffer peri-infarction zone. Wastes from the infarction zone are removed through it, and products necessary for reparative processes enter there to the same way. The larger of infarction peri-infarction zone interface, the better the mutual effect of the infarction zone and systemic control. The peri-infarction zone can't be smaller than required for uncomplicated healing of the infarction. Several words about heart shape and size. In case of infarction, a part of myocardium becomes disabled to its function should be compensated. Hypertrophy of an intact myocardium develops. Healing of the infarction zone accompanied with the consolidation of scar leads to a decrease in its size. The heart shape is remodeled in such a way that its anatomic proportions are restored to favor its pumping functions. In the best case, the traces of infarction are difficult to reveal even after thorough investigations. Acute myocardial infarction is a complex and vulnerable process. In the most optimistic estimations, its complications are observed somewhere in the quarter of cases, if it is diagnosed and treated correctly. The immediate cause of complications is inadequate stress or distress. Have a little patience and we would see how distress is realized as complications. Standard mechanisms of complication. The cause of complications is distress or abnormal stress. It can be three types: hyperreactive, hyporeactive, or intermittent distress. The mechanism of complications, irrespective to a distress type, is always the same, with desynchronization or necrotic and reparative processes. Desynchronization of necrosis and reparations lead to loss of heart wall strength in the infarction zone with cardiac aneurysm or heart rupture outcomes. The result of hyperreactive distress is an intensive or rapid migration of polynuclears to the infarction zone, with acceleration of necrosis and destruction of infarcted myocardium and lag behind of reparative processes. There is the desynchronization. Fast destruction of myocardium in the infarction zone has one more consequence. Like high concentration gradients of all products form in it along with boundary with peri-infarct zone with the electronic instability of the heart and as a result arrhythmia. In hyporeactive distress, there is a case everything develops slowly. Systemic reactions are sluggish or are absent at all. Thus, there are problems with the infiltration of polynuclears to the infarction zone and the necrotic phase is slow, which leads to the delay of reparative processes and their slow development. There is the desynchronization again. Hyperreactive distress with a sluggish disease pattern determines large sizes of aneurysm, and as a rule, heart rupture occurs in the thinnest area of aneurysm. Intermittent distress means superposition of the above mechanism by the formula out of the frying pan into the fire, and everything becomes much more dangerous. Classification of acute coronary syndrome. According to International Classification of Disease, we find it in Chapter 9, Diseases of Circulatory System, and we usually code it in by code I20 till I25. Whereas, for example, I20.0, it is unstable angina with all its forms, and I20.21, it is ST elevation and non-ST elevation myocardial infarction. And another forms we can find in I23 and I24. Classification. We are told several times about it. It is three forms of acute coronary syndrome. It is ST elevation myocardial infarction with occlusive thrombus, ST elevation, and Q waves. Here are the main difference that it is presence of cardiac enzyme elevation. Non-ST elevation myocardial infarction. It is non-occlusive thromb. It will be no ST elevation, no pathological Q in most cases, but cardiac enzyme elevation is still present. And unstable angina, it is non-occlusive thrombus with no ST elevation, non-Q wave, but here is absent elevation of cardiac enzymes. Myocardial infarction we can classify due to anatomic perspective. It can be transmural when it goes through the whole thickness of wall, and non-transmural that can be subendocardial and subepicardial. According to localization, it can be anterior, lateral, posterior, septal, inferior, and right ventricle myocardial infarction. According to clinical periodization, it can be acutest, it is the first hours after myocardial infarction. Acute form, it is predominance of necrotic processes. Subacute form, where it starts a predominance of reparative processes over the necrotic processes. And post-infarction patient, it is consolidation of post-infarction scar. According to course, MI can be non-complicated and complicated. And complicated, you remember from the mechanisms, according to type of distress, can be hyperreactive or hyporeactive. Symptoms. The cardinal symptom is chest pain experienced at the thinnest around the chest and radiating in the left arm and left angle of the jaw. This may be associated with diaphoresis or sweating, nausea and vomiting, as well as shortness of breath. Sorry, one moment. In many cases, the sensation is atypical, with the pain experienced in different ways or even being completely absent, which is more likely in female patients and those with diabetes. Some may report arrhythmia, anxiety, or sense of impending doom, or anger, anemia, and feeling of being acutely ill. The description of the chest discomfort as a pressure has little utility in aiding a diagnosis, and it is not specific for acute coronary syndrome. Common localization and patterns of chest pain you can see here. It is a different forms. All of them are typical. All of them are possible. It is a mid-sternum with left shoulder and down, both arms, neck and arms. It can be substernal radiated to neck and the jaw. It can be epigastric radiated to the neck and arms, and it can be intrascapular. The discomfort caused by myocardial ischemia is usually located in the chest near the sternum, but may be felt anywhere from the epigastrium to the lower jaw or teeth between the shoulder blades, or in either arm or wrist and fingers. And here you see a typical distribution of acute coronary syndrome with its localization depending on what artery specifically was damaged. In the patient's history and anamnesis, it should include any current symptoms and complete inventory comorbid conditions. An inventory of cardiac risk factors and complete family history are essential components. The history should also include information about the character and location of discomfort radiation or discomfort-associated symptoms and precipitating, exacerbating, or alleviating factors. The importance of family history should be underestimated. A detailed assessment, particularly of first-degree relatives, for the presence of coronary artery disease, and each of diagnosis is imperative when evaluating of patient risk factor profile. Physical examination. The result of physical examination of patient may be entirely normal. The presence of multiple risk factors or atherosclerosis symptoms increases the likelihood that chest pain is related to myocardial ischemia. Evaluation should include measurements of blood pressure and ankle brachial index, cardiac and carotid arteries auscultation for broods. Examination of chest wall, neck, and shoulders for deformities and tenderness may be helpful in diagnosing musculoskeletal chest discomfort. The physical examination may help identify comorbid conditions that impact therapeutic risk and decision making. The comparison of myocardial infarction and stable angina. According occurrence to pain, MI can occur anytime. Stable angina most often occurs due to physical or emotional stress. By mortality of pain, MI goes with the damage of heart and usually describes as severe, steady, and crushing. And in stable angina, it usually no damage of the heart. According to outcome, MI may be fatal, stable, usually not fatal. According to relieving factors of pain, in MI system persists after 15 minutes, can't be relieved by rest on nitroglycerin, and in stable angina, symptoms relieved by rest on nitroglycerin within 10-15 minutes. According to the duration of pain usually lasts for more than 15 minutes, and for stable angina it usually for less than 15 minutes. Discomfort usually here is transient, lasting 3-5 minutes. And here you see ACG, typical ACG changes for non-complicated myocardial infarction according to stages. The first block, it is a normal form ACG complex. Second, it is acutest form when it starts ST elevation and Q wave become a little bit deeper. Third and fourth, it is acute myocardial infarction when it is the highest level, highest rise of ST elevation and the deepest, the biggest pathological Q wave. In subacute form, when it is prevalence of reparation processes, it is returning of ST elevation to the ESA line. It can be still negative T and Q wave still pathologic, and it will be pathologic. It can't be returning of pathological Q wave because it means necrosis of myocardium. And the last one, it is a post-myocardial infarction ACG with a pathological Q wave because it was necrosis, it is a scar of myocardium, but it is returning to normal ST segment and it is returning of positive T wave. And according to changes on ACG, in which leads we see these changes, we can suspect localization of myocardial infarction. For example, if we see the most changes in leads 1, AVL, V5, V6, it is a lateral MI. If we see changes ST elevation in leads 2, 3, and AVF, it most specific for inferior myocardial infarction, V1, V2 for septal myocardial infarction, and V3, V4 for anterior myocardial infarction. Complications. They may occur immediately following the heart attack or may need some time to develop. Acute complications may include heart failure, aneurysm of the left ventricle, myocardium, ventricular septal rupture or free wall rupture, mitral regurgitation, in particular if the infarction causes dysfunction of the papillary muscle, Dressler's syndrome, and abnormal heart rhythm such as ventricular fibrillation, ventricular tachycardia, atrial fibrillation, and heart block. Longer-term complications include heart failure, atrial fibrillation, and an increased risk of second MI. You see, according to time after myocardial infarction, what complications can we meet the most often. If during first day it is sudden death and arrhythmia, arrhythmia the most often complication, and during first week. During first year, on the first place it goes chronic heart failure, but it is still actual arrhythmia, aneurysm, and thromboemboli in a very long period, during 10 years. The most dangerous complication is chronic heart failure, and it can be recurring infarctions and arrhythmia. Diagnosis. First of all, we do a blood test. First of all, it is cardiac biomarkers, and additionally, it is checking of white blood cell level, cholesterol, and C-reactive proteins level. They can be affected by MI. It is due of electrocardiogram or ECG. I show you changes. It is B-mode and Doppler and intravascular ultrasound. It is gold standard in diagnostics of acute coronary syndrome. It is vascular catheterization and angiogram and other imaging tests. We always need a complex of several factors for diagnosing acute coronary syndrome and MI. It can be just symptomatic, it can be just ECG or just biomarkers or just ultrasound. It always complex of several, minimum 2 of these factors. For example, symptomatic and cardiac biomarkers, ECG and cardiac biomarkers, but patient can be asymptomatic, and other combinations. Criteria for diagnosis. A combination of criteria, what I told, it required to meet a diagnosis of MI, namely the detection of an increase or decrease of cardiac biomarker, preferably high sensitivity cardiac troponin, with at least one value above the 99th percentile of upper reference limit, at least one of the following. Additionally to cardiac enzymes, it is symptoms of ischemia, new or presumed new significant ST wave changes or left bundle branch block on 12 leads ECG. Next, development of pathological Q waves on ECG. Next criteria, it is imaging evidence of new or presumed new loss of viable myocardial original wall motion abnormality. Intracoronary thrombus detected on angiography or autopsy. And a scheme of biomarkers, you see it here. The most early, it is myoglobin. During first day in acute form, the most usable, it is CKMB, because it's not enough time for troponins, and after it, the most usable and the most specific cardiac enzyme, it is troponin T or I. Less specific, it is LT, AST, and LDH, but usually they are not usable, just for addition to main cardiac enzymes. Indications for measurements of troponins. Cardiac troponin I and T have displaced myoglobin and creatine kinase MB in the preferred markers of myocardial injury. Serum levels increase within 3-12 hours from the onset of chest pain, peak in 24-48 hours, and returns to baseline over 5-15 days. Troponin levels may not be detectable for 6 hours after the onset of myocardial cell injury. The most sensitive early marker of myocardial infarction is myoglobin. Troponin levels should be measured at presentation and again 10-12 hours after the onset of symptoms. When there is uncertainty regarding the time of symptom onset, troponin should be measured at 12 hours after the presentation. The risk of death from the acute coronary syndrome is directly related to troponin level, and patients with no detectable troponins have good short-term prognosis. Elevated troponin levels can occur in patients without acute coronary syndrome and are associated with adverse outcomes in many other clinical situations, including congestive heart failure, sepsis, acute pulmonary embolism, and chronic kidney disease. Other cardiac causes include myocarditis and aortic dissection. ECG. Here you see a CG of real patient with ST and T changes in leads 2, 3, and AVF. It marked by solid red cycles, and it is suspicion of ischemia of inferior myocardial wall. A similar changes is outlined in lead V6. It is dashed cycle. It is inferior to, you see, second, third, and AVF leads in acutest phase. It is just starting of ST elevation. It is an inferior STEMI 2 with a right bundle branch block on ACG. There is a procal depression in lead 1 and AVL. And comparison, the differentiation of non-complicated and complicated myocardial infarction. According to criteria, the level of blood leukocytes, shift of leukocytes, time of maximal activity of enzymes, initial period of protein-carbohydrate complex growth, the period of reaching maximum protein-carbohydrate complex concentrations, and interval between maxima of enzymes and protein-carbohydrate complexes. And by the return of ST segment on ECG to isoline. According to this difference, we can define, is it non-complicated with aeroreactive stress, is it complicated with hyperreactive stress, or is it complicated MI with hyporeactive distress. That's all for today, which I want to discuss with you. As usual, if you have questions, if you have comments, if you have some problems or difficult moments, you can write in comments under the video or in our department Facebook page. And I ask, as usual, all students who listen in my lecture, leave in comments under the video your name and group number for controlling the attendance. For today, that's all. See